Okay.
Hey,
Okay, we're
hey.
back again. Topic this week, we have a list of topics. I can't wait to do the sacodometry one, but today we're going to talk about a case, one of your cases in particular, and things that I've seen in my office too.
Sure.
A common thing is maldebarkment syndrome, which means, mal is bad for all you Spanish speakers. Bad getting off a boat. You feel like you're on a boat, right? And another thing that I see with it is Alice in Wonderland syndrome, which would be the same kind of mechanisms. For myself, when I was in high school, I played soccer 1 year, and I was just aggressive. I might as well have played football. And I remember I would look down at the ground and I'd be like, "Oh, that's really weird because it's far away, but it's close, but it's far. I don't know. I can't tell how tall I am right now." And it was like up and down and round with my head down, which makes sense, right? And putting the sacule and
We
so
we know these things now, yes.
yeah. So it's fun. I mean, this is why I had to experience it so that I can now come back and work with patients and go, oh, this is a, but
I
Mal
get
Debarkment,
it.
yeah, I've
Yeah.
experienced it. And there are many things I don't need to experience all the things. I'm good. I'm really good with it. So
Yeah.
yeah.
I'd like to not have everything that I work on because oh my
Yes.
gosh, it's
Yeah.
and some people just the suffering is
Yes.
absolutely horrible.
Yes. And they suffer because they can't find answers. And I don't know everything. I try to. I have one case that's gone on way too long, in my opinion. It has been a bugger, but no, I don't know where to refer this person to help them. So I'm digging and digging and digging. You've kind of helped me through this one. We've talked about it.
Oh, sure, sure. Yeah, and
Yeah.
that's there may not be a better referral than you.
Yeah.
That is possible. It happens.
Yeah. And it's
You want
it's
to get
hard.
rid of them and you can't
Yeah.
because
You want to do better for the patient. And it's like, who do
yeah.
you go to? Same goes with
And Ted Carrick is too busy for everybody, for all of us to
I
give us
know.
the hardest of the hard, for sure.
Yeah.
Even though he's a vampire,
Yep.
he
Yeah,
does
and I
need
have
food
patients that
occasionally.
literally beat themselves up and they're like, my shoulder hurts. And then I have other people that are, I looked at a piece of bread.
Yeah,
I stepped weird and they fall apart. I mean, and they're quote unquote good or bad people, right? The way they live their life is for a purpose and they fall apart at the littlest thing. And other people don't even respect life and they, do the craziest things and get away
they
with it.
can drink and smoke and ride roller coasters all day
Yep.
long. They're just
Emotional up and down, light,
yeah.
your light reflex, all of it is
It's
crazy.
like that's fine. I just yeah, my thumb hurts a little bit. And you're like, really?
Yeah. I'm just going to take a break here for a moment. While this podcast is for educational purposes only, we would love a like, a share, shoot, even a dislike, a comment, so that the algorithms pick us up so that people can, maybe learn a piece of information for their health or doctors like to listen to this in the background. It's possible. But if you don't mind like, sharing, subscribing, commenting, any of those things would be greatly appreciated. Thank you. Yeah.
Yeah.
All right. So Mel DeBarkment, tell us about this patient, maybe like some stats on her, what
Well, it's a
what she's
it's
been
an
through.
interesting thing. What this patient has been everywhere, pretty much. You've got the Mount Sinai Clinic in New York that's kind of one of those that started to do these full field optokinetic therapies where they get in and they just roll the head back and forth and they do full field optokinetic. And that's what's supposed to recalibrate that visual vestibular otolithic apparatus. And they've had some people that they've done really well with. And again, I've talked to other doctors that we know who've seen patients from those clinics, and it's like,
Mhm.
there are people that come out of there worse than
That
not, right?
sounds
And it happens, right? It
sounds
happens.
very
And
aggressive. I'm not gonna lie. That sounds
well, it's a
very
hardcore
aggressive.
therapy. Yeah.
Yeah.
What is an opto again? And I'm gonna grab my optokinetic tape just so people understand what we're
Okay.
talking, right?
Okay.
That's the thing. You have really done a good job in helping me realize don't just say things and think everybody understands them all the time. So, an optokinetic stimulus, what we use in our clinics is something like this. And I'm sorry, I apologize to those of you who have maldebarkment that are watching this.
Close your eyes. Just close your eyes.
Yes, what
Where's
we
Waldo
do
Strip?
what we'll do on examination a lot of times is look to see how people register this kind of a stimulus. And we may do it in all sorts of degrees, but the
Mhm.
classic testing for
Speed,
optokinetics at the
slow. Yeah.
bedside is vertical and horizontal. We can do a whole different load of things with it, but what they're doing at this Cedars-Sinai vestibular clinic, I believe that's the name of the clinic, is they're bringing you into a room that basically is full field, meaning your entire visual field is occupied with that. They're moving it, maybe based upon like a Fukuda step test, which if you don't know what a Fukuda step test is, again, I'm bringing these things in and I want to explain it. You're going to stand somebody up. You're going to have a march in place
Eyes closed.
for a certain period of time with their eyes closed. And what a normal, fully perfectly calibrated vestibular system should do is not move. You should march in place and stay in place.
Hmm.
What most people do is they will drift a little bit away from where they started. What
Or
people with
turn.
maldebarkment,
Yeah.
what people with maldebarkment do is drift and turn a whole lot. And the thing that's really interesting that you see is if you couple it with an ophthalmological examination or our VNG examinations or things like that, you're going to find different degrees of like nystagmus or deviation from central with the eyes, right? You can do that with an ophthalmoscope as well.
Hmm.
What you'll find is the nystagmus and the Fukuda step test tend to have a correlation. I'm going to drift on my Fukuda step test in the direction of my nystagmus. Classic maldebarkment patients have a tendency to do that. So what they'll do is they'll maybe calibrate the direction of the optokinetic stimulus according to that, and then they have people roll their head back and forth, or they may do some other things vestibularly with people at that clinic. And they go, we found the cure for maldebarkment. That's what we do. Mayo Clinic is doing very similar things now. That's in Minnesota, Rochester, Minnesota, and they've got a clinic in Phoenix, Arizona as
Hmm.
well. I'm not sure if the Phoenix clinic does it, but she's been to Minnesota. She's from my areas, but again, she's very well connected and has been through a lot of these things. She's seen
Hmm.
virtually every neurologist or ENT in the region. They've done all sorts of different things with her, from giving her ginger to giving her, some of those ototoxic medications that are supposed to quell the system, to gabapentin,
Yeah.
to
That
uh,
medication, I tell you, I have a
it, it's
trigeminal
it's a
nerve case right now.
it's a tough medication because what are you doing with it? Basically, the thought process is if I can dehabituate your GABA receptors and slow your brain down,
Hmm.
everything chills out. Well, it just made her worse.
Yeah. And had to
She
give,
came to me,
I
she
want
was
to show,
referred by that. Oh, go
I'm
ahead.
going to try to put this up. This is a vestibular system. This
I've
is
got one too.
this is the part where you hear. This is the part where you hear. And then these are the parts that tell you if you're tilting or turning. And then right in the center of all of that is the otolith. That's where those little guys live. And this is adult human size at 6 months in utero when the baby's flipping around. It sits in the bone. It literally sits right there. But people don't realize when we're flipping and turning, just to respect this thing and the little hairs in there. I mean, it really is a magical sensory organ. I just love the vestibular system. Anyway, just to give people to orient
Yeah.
people.
Yeah. So that's a true size reference. This is a model from
Yep.
vestibular first.
And people can make that. You homeschoolers who want to make a 3D
No,
design, they have the map on there. I have that guy
yeah,
too. Yeah.
no disclosures. I got it from vestibular first because it's
Ditto.
a really
Me
cool
too.
thing to show
And
people.
my
Yeah.
and this little thing that I got from vestibular first. The
Yeah.
Yep.
Love those guys. They're fabulous and they've got online training that's really good and everything.
Yep.
They're super good.
And they
Um,
think about it too clinically, not just like, oh, this A plus B equals C. It's A plus B with a little division and multiplication and gets us to C, which is
yeah, and
what we're
and
doing and
and
is missed at some of these clinics.
that's the thing. We like that. And as I was getting to with this patient, she's been everywhere. And most of these places, what they'll do is they'll give you some kind of a diagnosis, maldebarkment in her case,
Hmm.
and then you get put into a protocol.
Correct.
And the problem is
Yeah.
with a protocol that is kind of one size fits all, we have a tendency to have a certain amount of people that do really well with it
Hmm.
and a certain amount of people that don't respond. Just like with medications, just like with
Taking tests, the way tests are applied in school,
Standard
and yeah,
chiropractic care or
yep,
physical therapy or anything, if you do the same thing with everybody,
yep.
you're going to have, an 80-20-20 or an 80-10-10 or a 60-20-20 or whatever it is.
Mhm.
You're going to have some people that fall through the cracks because they've got a more complex syndrome. And this patient had a more complex syndrome. She was referred to me from a functional medicine practitioner in the area who we've had some good interaction in the past, which is great.
Mhm.
And this provider wanted to do, looked at her labs and was doing some nutritional things, and it was good. It was sound and it made sense to me. I was fine with that. Definitely. I'm like, hey, I'm on board with you working with them, but they do some other things in their clinic that are kind of cool as well for some people, like hyperbaric oxygen therapy. And I
Mhm.
said, okay, how'd you do with the HBOT? I felt terrible afterwards. The boat was rocking even more. So with maldebarkment people, they feel like they're rocking or they're on a boat all the time. This patient, you put her on an elevation table and you take her feet off the ground. Oh boy, like I don't know where I am. I'm gonna fall. I feel like crap.
They can be as
No,
subtle as lightheaded when they go from sitting to standing, or just a little bit. I mean, that still falls into that
it can
category
be diagnosed as
versus
that, but
vertigo. Vertigo is like hard spin. This
correct. When
maldebarkment
people
is not going to have that typical hard
there's
spin.
not a moment of spin, but there can be periods of that mixed in with it.
Yep.
We could get some of that, what you describe more of an orthostatic intolerance, which is
Hmm.
yes, I've got that. And that's the thing that you tend to see with these. And again, if you take Jeremy Schmo's nodulus class, not modulus, nodulus, if you take that, he talks about a lot of this stuff where it's like, gosh darn it, you've got multiple layers of this. You've got the like we talked about the last time, triple PD,
Which
which
is triple PD.
conceptual, postural, dizziness.
Okay.
I missed the third D in there or the third P in there. But these people get diagnosed with, again, you get a label and then you get thrown into vestibular rehab, which a lot of vestibular rehab centers, they kind of do the same types of things with everybody. It's you're walking down a hallway,
Yes.
read the card to a
Walking
metro.
around cones. Yeah.
Yeah, things like that, which are all great therapies, but not great therapies for everybody all the time. And that's what this
Mhm.
patient, so I asked her, I'm like, how'd you do in the hyperbaric? And I knew the answer already
Mhm.
before she even gave it to me, just kind of looking at her, even before I'd examined her. I
And
did terribly.
some of the reason you ask that question is even if you think you know it, you could be wrong. But more than
Yeah,
that, it's it's also helps the patient feel heard, and
yeah.
there's
Well,
a
in the
there's a
history, again, if you have ever been taught by Ted Carrick, the history is going to give you 90% of what you need.
hmm
Are you just smart enough to listen to the patient?
yeah,
And are you smart enough to ask them the right questions? And
yep.
and are you smart enough maybe to move him off of the things that don't matter as much, which he does better than anybody in the world?
Uh-huh.
Um, it's really interesting, and I've tried to learn that because yes, I want to hear you. I want to hear everything that you have to say, but sometimes it doesn't really matter what the layer of dog food was like in the dish, so
Yeah.
on and so forth. But people
Yeah.
really,
I
you
ask
know, your left brain people really give you all the details.
I ask a yes no question, and I get what did you have for breakfast? Well, we went to the we went to
Yeah.
Disneyland, and then we came home, and my husband did it, I'm like, what did you have? Or a simple yes no question, and I get the whole story. Yes.
And
Anyway,
they
go
haven't
ahead.
even answered the question that you wanted to know. It's like I really wanted to know if you had eggs or not, right?
Yeah.
All these things matter, and it's really interesting to see how she'd come along. But the hyperbaric didn't do well for her, and I said, okay, well, now that already adds to what I'm thinking her clinical constellation is. When I see people struggle with
What was her
hyperbaric,
complaint coming in? Was it the dizziness?
the MDDS, yeah,
Okay,
she
okay,
she she'd been referred to me because it's like,
okay.
hey,
That's right. Okay.
McLaren's got a different perspective than what you've had. Maybe
Hmm.
not. Maybe he's
Right.
going to, the Dr. Simon referred her in and Dr. Simon didn't know what I was going to do
Hmm.
because she didn't know what I was going to do. But I
Yeah.
got her in and I heard that. And right away, again, the first thing I go to with most of my patients on my clinical exam is the pupillometry because I want to know what your relatively undenatured autonomic status is before I start doing things that could influence it. An eye
So
movement, a balance test, et cetera, et cetera.
we're going to do a whole thing on pupillometry, but this
Components,
particular
yes.
one, takes a picture of the pupil, you do it on both eyes, and it measures how the pupil size, how much it constricts, the time it comes back to baseline, and there are
You get a
standards
lot of
for
data
that.
points. Yeah,
And
you get a
with
lot of
that,
data points with it.
yeah, we'll do different video going through that paper that Carrick
Yeah, we
did. It
promise we will discuss pupilometry
yes,
at some point.
just so people
But
know what we're testing. It's not just a light in the eye. It's we hard measurements, objective measurements.
very much, it's a dynamic challenge that tells you how the nervous system and the autonomic system, which is part of the nervous system,
Hmm.
how the brain and the autonomic nervous system are regulating. Basically, what I'm looking at with that and a few other markers is, can the brain get enough fuel to handle a certain stimulus? And in her case, it didn't. And I knew that as soon as she said the hyperbaric didn't do very well for me, because the thing you tend to see, everybody's demonized, and we've talked about this already a little bit, the sympathetic nervous system.
Hmm.
It's like, well, everybody's doing vagal hacks and all those kind of things. Now, we've talked about this, right?
Yeah, right. Not
Everybody
for
wants to do
everybody.
all this. Yeah. Everybody wants to do this vagus nerve stuff because you can find a vagus nerve stimulator for 99 bucks on Amazon now,
Yeah, yeah.
or less, probably less than that. And it's good for you and it relaxes you and all these kind of things. Like I said, I had a patient that put himself into a full-blown anxiety disorder because he was overstimulating his vagal apparatus. In the case of hyperbaric oxygen, one of the things that you tend to see is it tends to be relatively parasympathetic stimulating or relatively sympathetic nervous system suppressing. And in
Hmm.
her case, she had an already suppressed sympathetic nervous system
Hmm.
superimposed or underlying or involved in this maldebarkment presentation, which is like, now she's got the classic maldebarkment. I'm on a boat, I'm rocking all the time, but she's got the orthostatic intolerance. Like you said, I love that you brought that up. She's got some of that superimposed with it. So she gets in the hyperbaric, she gets out, and she's like, man, I am really on the boat now. Well, yeah, you exacerbated your syndrome with this.
The ability for your muscles to contract quickly to stabilize you is sympathetic,
Well,
and
anything
you
is
shut
sympathetic.
it off.
The first thing any sensory modality does when it comes in is it fires right to the IML to
Hmm.
dilate blood vessels so that you have nerve blood flow and fuel delivery to process that sensory modality.
Yeah,
It's the first thing that happens. The thing that we do later on is we modulate it.
right.
That's the thing. It's like, but you've got to have a sympathetic component. You touch somebody, you talk to somebody, you smell something,
You're
you
doing
shine
it.
a light in the
Yes,
eye,
yes.
you're getting a sympathetic activation along with a parasympathetic.
Yep.
Very, very much. And you need it because, yeah, again, I need to be able to get blood up here and to the muscles and all those other things. I got to dilate those arterioles.
Hmm. Driving down the road, I need to be able to
Yeah,
hold on the steering wheel, which I usually drive down low here or up here. And if
yeah,
I turn my head, I need to make sure that I don't fall over, that my pupils can refocus and dilate. It is a
yeah.
very
The,
coordinated thing.
and that's the thing. I've talked to Isla Wolf about this before, and she's got the great analogy of, the sympathetic and parasympathetic system are not in an MMA battle with each other. They're in a waltz.
Yes,
They're very much they're two components of the same system. And if your
right.
brain works well, you can definitely have flexibility to go back and forth between the two. I've used the term vacillate in the past. That's not a good term because vacillating is like a passive, wimpy thing. It's no, we need a
Okay.
very active inhibition, excitation
Hmm.
roller coaster to be on. I want to be able to walk up the stairs and then digest the food. I want to be able to do both. I want to fight the tiger. I want to be able to digest the food and stop the robber from coming into my home or whatever it
Yeah.
is.
Yeah.
And then go back and be able to go to sleep after it's done.
Yeah. So she had weak sympathetic basically
She
is
had dysautonomia. Yeah, she had
yes.
dysautonomia, which is a dysfunction of the autonomic nervous system in context or in concert with her maldebarkment, which is one of the reasons why she's done all of these treatment strategies and, if anything, had no success or gotten worse because
Hmm.
they're overtaxing a fragile nervous system.
Right.
So you come in and you do this, like, walk down the hall and do this crap to 120 beats per minute metronome. It's not crap, but it was crap for her at the time because it's right
Yes.
therapy, wrong time.
Yep.
It was crappy for her. It made her feel crappy and it made
Hmm.
her worse.
Hmm.
Or you do this full field optokinetic stimulation where you roll the head, or all these kind of things that are, again, they're great therapies on their own when they're clinically indicated, which is, again, I'm going to say it. You know, I'm going to say it. I'm going to say it over and over again. Find a carrick trained individual in your area to
Yeah.
diagnose you, to
Yeah.
do these tests with you, to see what therapies are clinically indicated for you before you just jump into the deep end of the pool into like a, a
Oh, you're dizzy.
non-specific
Let's
program.
adjust it. Yeah.
Or that, yeah, that's the
Yeah.
thing. It's a lot of times there are people that will have these maldebarkment type of things, and they'll see a general practitioner or chiropractic, and they'll do pretty well.
Hmm.
There are some
Well,
out there that don't.
meaning the symptoms went away doesn't mean their autonomic system adapted correctly.
Well, and
There could
it
be
doesn't mean
a
all maldebarkment
right.
syndromes have dysautonomia as well, for sure.
Correct.
Sometimes it is an otolithic miscommunication,
Hmm.
and sometimes having a cervical adjustment or a rib adjustment or something is what is indicated to calibrate that apparatus. We probably have loads of general practitioners of chiropractic that have done pretty well with some maldebarkment cases.
Hmm. Hmm.
It's out there.
Yeah.
Doesn't mean everybody should get an upper cervical adjustment or everybody should get a rib adjustment or everybody should get their thumb adjusted or anything like that that maybe
Yeah.
worked. I had a patient,
So,
and it's
okay.
interesting. I mean, where this patient had been, there's just some studies out there in the last 5 years, 6 years that were really not well done, where you get a couple people that did certain things and they didn't get a certain thing, even though they saw a bunch of people in their hair salon.
Hmm. Hmm.
So it's like, well, we found the
Gotcha.
cure for this thing.
Yes,
It's
this
like, well, I had
lockdown
one
period.
patient.
Uh-huh.
Yeah, I had this one patient in who, what we found for her that was really interesting. I put a hot pack on the median nerve and the post-traumatic headache went away. I'm like, well, I found the cure for post-traumatic headaches.
Right?
Hot pack on the
Exactly.
right wrist. Yeah.
Yep.
It's like, no, I
Yep.
just did median nerve stimulation and it fed her neurology really well.
Yeah. So
But
back to clarify, person sent with a diagnosis, it doesn't explain how it got there. And there are so many ways in which it could get there or, be staying sticking around.
100%. And you've done all the things that are indicated for that ICD-10 code or
Hmm.
whatever it is, and they're non-responder.
Hmm.
It's like, do you have the
Some,
diagnosis right, or did you miss something in the boat? I would say a lot of times with these maldebarkment cases that aren't responding, you're probably seeing some kind of superimposed dysautonomia.
mhm.
In my
Especially if
experience,
it's been a while. I think there's probably a time
and hers is years.
that, and then I add in with all of those, I ask, did you have an infection as a kid? Have you recently been sick? Is there, something else going on?
Postmenopausal
Because
for her.
people don't realize,
Postmenopausal.
post menopause, your hormones, yep. People don't
Menopause is what
realize
started it.
virus, bacteria, the
Yep,
infection, and the cure are both ototoxic and can affect that vestibular system. And what little bit on this person they could be fine, that little bit on another person could wreck their vestibular system.
100%.
But yeah, those postmenopausal women are the worst in regards to all the things that lead up to it. They are not the worst as humans, but their poor
But
symptoms are
they've
the worst.
got a clinical constellation that's very difficult. And the problem is when you look at hormones and hormone status and things like that, it's the lifetime load of estrogen very much matters for a female,
Hmm.
in addition
Lifting
to what
weights,
happens when it drops off. Well,
enough
yeah.
protein, enough fat with the protein to absorb it, and collagen, all the things.
Well, and when you talk about
Stress.
all that stuff, you're talking about supporting the endocrine ability to move from the ovaries to the adrenal glands as
Mhm.
menopause happens.
Right.
Because what should happen normally is you go, yeah, eventually the ovaries are going to
Stop producing.
malfunction and stop
Yep.
working. What should happen if you are, again, a relatively normally calibrated human? You should switch your primary production of estradiol from the ovaries to estrone from the adrenal glands and
Yep.
be able to compensate. But let's talk about who's got good functioning adrenal glands
Hmm. Not working women.
and your
Women who can do everything. The
estrogen
type
levels.
A, I mean,
Yeah,
dare I say the feminism movement has not been good for menopause for many.
it's tough. Yeah, it's tough. And
Hmm.
that's the thing. You could probably do a longitudinal study and link. And again, you throw in lifetime estrogen load. Like I said, what are we doing with birth control? What are we doing with microplastics? What are we doing with all these things
Hmm.
that has taxed that female endocrine system for so long? And you could talk about how the way studies were done that became protocols for birth control that weren't even done on women, et cetera, et
Mhm.
cetera.
So
It's very
did
difficult.
you with her, did you evaluate hormones at all, or had she at some point had those
She
evaluated?
Again, she's working with a functional person that I
That's
trust
right.
on it, so I know
Okay.
that's being addressed in the right
Okay.
way now.
Okay.
I'm very comfortable with who she's working with, so I'm like, okay, I
Okay.
don't have to do that.
Yeah.
But at the same time, we go, okay, we're going to quell that hormonal fire. We've still got this entire skew of that otolithic versus labyrinthine axis.
Hmm.
And we've got the autonomic nervous system issue that needs to be corrected along the way. And the poor thing has had, since I started working with her, multiple big time life stressors, parents
Mm.
having issues, and so on and so
They
forth.
all hit. They all hit, I swear, at the
It's
same time for
everything.
people.
Again, she's in that postmenopausal age where it's like now your parents start to go to long-term care, or worse, you lose somebody in your family,
Hmm.
and it's another thing to light that system up even that much more. So, but I'm working with her and we're having good signs of progress. You throw on top of it, and again, Jeremy Schmo in the Nodulus program talked a lot about thoracic outlet as a component of maldebarkment, dizziness, or other vestibular things, because the glymphatic system clears inflammation from the brain, and you need a thoracic outlet that is patent for that to happen. She's got thoracic outlet issues on top of everything else.
Hmm. Hmm.
And it's one of those, like, those hadn't
Interesting.
been appropriately cleared by all these other clinical places that she'd seen. I do that with her, and it's like, oh my God, that's the best I felt in 16 years.
So you just did, I'm sorry, back up. You did rib adjustment on her?
I did this thoracic outlet adjustment that Dr.
Okay.
Schmo demonstrated at Nodulus,
Okay.
which is it's rib, clavicle, shoulder, a little bit of first. It's a cool adjustment.
Okay.
I showed it to my scholars at the board review,
Uh-huh.
and then I don't think I was on camera for that, but then I was on camera when I taught CNS2, which
Uh-huh.
was spinal cord and peripheral nervous system. And of course, Dr. Schmo gets the shout out for it because it's like it's his,
Yeah.
right? But it's Professor Carrick's that we all make our own art
Yeah.
and come back to. The brain-based adjusting course is fabulous.
Hmm.
It's kind of taking some of those concepts and
So are
bringing
you
it
saying
in.
this adjustment cured her?
No, I'm not saying it cured her, but I'm saying it improved that glymphatic drainage potential so much
Okay.
that she felt a lot lower symptom burden for a
You
little
needed,
while, right?
oh, okay. Okay. Were
Yeah.
you doing other things with that?
I did head eye vestibular motion in a
Okay.
metabolically graded appropriate fashion with her as well.
Okay. So were
So we're
you
doing
doing
a
like,
little bit. Oh, go
did
ahead.
you have a pulse ox on her? How were you monitoring her
I use that
autonomics or pupil?
pupillometry. I
Okay.
use the pupillometry and I use a pulse ox,
Okay.
and I'm looking at what happens dynamically with those pupils as I'm doing a head thrust or a
Hmm.
head turn
Hmm.
or an eye movement or things like that. And I'm rechecking the pupils to see, did I make that more suppress? Did I suppress that system that was suppressed more, or did I bring it into an ability to come to threshold?
In a typical visit, how many times are you taking a picture of the people?
Depends on the visit. With that one initially, I will
Uh-huh.
do it more than once for sure. Probably, sometimes 3 or 4 times.
Okay.
Generally, once I've seen you and I kind of know where our fragility lies, I'll do it once or twice. I'll do a pre and a post maybe.
Okay.
If I introduce new therapies, it's like I'm going to do it at the beginning of the visit and go, do we have better fuel delivery than I saw on you
Hmm.
at the end of the last visit? If I do, then I'm like, okay, the exercises that I've given you at home, I don't do intensives in my office because just the way my life works. So I send people home with stuff. And again, the magic with neural rehabilitation is to do 3 treatments a day over 5 days to build neuroplasticity. It's like that 15 number is kind of the number to start to
Yeah.
build plasticity. So
Yep.
if you do your stuff 3 times a day for 5 days, then I know, and I may be like, I've got the telemedicine application on the pupillometer too. So I can check your pupillary data when you're not here. If you
Hmm.
can't, if I can't get you over here to swing by before that,
Yep.
but I'm doing a pre and a post check, and then I may get data on them before I see them again,
Hmm.
or I'll get data on them again when I see them. And if I like what I see, we can kind of add exercises. We can add amplitude to our saccades. We can
Hmm.
add some different head movements or some different vestibular movements of a thrust or a
Hmm.
surge or a bob or a weave or a
Yeah.
hike or whatever you want to call
Yeah.
it.
Yep.
We can do a repositioning maneuver on somebody, maybe, where when they're very metabolically taxed, a repositioning maneuver is a very high grade stimulus.
Hmm.
She's had 60,000 repositioning maneuvers.
Yeah.
Maybe not literally, but she's had repositioning maneuvers at every clinic.
Are they done? Do you think they're done well?
I think some places are probably really good at them.
Okay.
I would expect Mayo Clinic has probably got a good training on how to do those.
Hmm.
Was it applied in an appropriate fashion? That's a topic that we're going to talk about too, is how
Hmm.
many rolls do we do a visit? How many repositioning maneuvers? And how do you decide to do the maneuver that you do? We're going to talk about this stuff as
Hmm.
we go. But I think they were applied appropriately,
Okay.
probably. But again, it's bringing a nuke to a knife fight.
So where is she now?
So now she's at the point that where she was so suppressed that doing frontal lobe activations in the left hemisphere was like a go zone for her. Doing right hemispheric activations was an absolute no-go zone. And you could see it. You do one or two saccades to her left, she like starts to melt.
Mm-hmm.
We're at the point where we can do a little bit of those now at
Hmm.
home. We can do a little bit of some head thrusts that are very controlled on her own.
Hmm.
We're at a point where I can raise her on my table and she doesn't start to freak out and wonder where the world is, which is really, really cool. So
Hmm.
we're doing better. Again, and again, if I did nothing other than decompressor thoracic outlet, I think she'd be ahead of the game. But that coupled with other things, and there's reasons that's compromised that link to what her postural exam looks like, her dynamic postural exam. You go, yeah, I've got some counter lever activity and some other things here that mean basically, I think, what you'll see people all the time, they're going to have some internal rotation on a shoulder or a head tilt or things like that that are compensations for what they perceive as they're going to fall,
Yeah.
which is,
Or
again,
their
something else we're going
relationship
to
with
talk about is,
gravity.
yeah,
Yeah.
we're talking about looking at posturographic data and why we would do vestibular maneuvers or, other therapies based on what their center of pressure looks like and things like that. Yeah, she's got significant otolithic miscalibration.
Hmm.
So again, with a repositioning maneuver,
Are you able to even do translatory stuff like
oh
push her
yeah,
into the air?
I translate her to her right, and speed matters on those as well. She does
Yep.
really well with slower translations, not so well with fast translations.
Uh-huh.
Some maldebarkment patients are the opposite.
Yeah. Yeah. I always err on the side of slow first, obviously,
Well,
and
I think
then
that's the
to
thing. You
test.
can, yeah, I think slow, because it's easier not to compromise somebody, and you
Hmm.
can figure that out in your exam pretty darn quick with people again.
Hmm.
And they'll, I mean, a lot of these maldebarkment people will tell you, it's like, ooh, that was terrible.
Yeah.
So that's the thing. If I'm taking somebody and I do this and they feel absolutely horrible, why would I want to have them do this at like 120 beats a minute?
Yeah.
Oh,
Yeah.
it's going to get better the more you do it.
Yeah. Um,
Maybe,
so
probably
how many
not.
times have you seen her?
Like four or five.
4 or 5. So does she notice improvement in her daily life? What is
Yeah.
she? Yeah.
Even with these life stressors and things like that,
Uh-huh.
she'll get migraines and things like that too. I didn't get to see her this week because the migraine was so bad she wasn't driving, but we're in the barometer season here as well. So
Oh,
it still
okay.
happens. But the thing that is great, she has not had a migraine since I started working with her until this week, and she was getting those like two, three times a week.
Hmm.
So again, that's that autonomic system starting to work a little bit better. Migraines and dysautonomia go together.
Yeah. Wow.
We know this for sure, but a
Hmm.
lot of the public doesn't. And that's the thing. What she's had the CRGP1 injections and have not had a lot of success with it,
What
which
is
is
that
again,
one?
there you're looking at what Emgality and I think Emovig are the classic injections for
What are
migraine.
they? Oh, okay.
Migraine
Okay.
meds, yeah,
Migraine meds.
CRGP1
Okay.
inhibitors, yeah.
Okay.
So they're going in and using the medication to decrease calcitonin gene
Yep.
related peptide levels,
Yeah.
and she's had all that and it hasn't done diddly poo for her, to be
Hmm.
honest with
Hmm.
you. Um, Again, this is the first time she's had a migraine in quite a while, and that was a more than once a week event before we started. So I'm having some successes. She's still not balanced by any means,
That
but we're gonna
barometric
get her there.
pressure is no
What's
joke
that?
on otolith. I have a patient that went through a windshield as a child, and he still has otolithic stuff goes on. He plays hockey, um, and for fun as a grown adult, it's good. I'm like, you know your risks. Have fun.
Yeah, yeah,
But
yeah. Have some
he will
fun.
be like, yeah, my neck was stiff because there were clouds. Like he is so sensitive to it, and I'm sure it's because there was damage in that system. So we've done, I have exercises to kind of stimulate that area to try and help him when that pressure is getting to him. But yeah,
When you
and I
talk
have
about the
other,
histamine pathways and that, we talked about that before too.
there's histamine pathways. Yeah,
Have you had him take like DAO or anything that's a histamine blocker?
I have, but it happens pretty quick on him, that pressure. So he does
Yeah.
like I have him do some I have him do some of this stuff in particular on him,
Well,
and it helps.
you
So,
found you found a so basically when you talk about a saccular activation, what you're doing is you're activating a certain part of the oolithic apparatus that
mhm.
calms down what we call the velocity storage apparatus, which will run roughshod with some of these people when barometric pressure changes because of connections to the histaminergic activating system and connections to what happens also with the barometer when you get fluctuations in the barometer, there are parts of the brain that'll swell that are very connected to the vestibular apparatus, and there are other parts that'll shrink a little bit
That
that are also
endolymphatic
connected to the
system.
vestibular apparatus.
Yeah.
Glymphatic and lymphatic, exactly. So
The
you're getting
endolymphatic, that little sac
oh,
right next
endolymph,
to that
yeah.
vestibular, that thing, just do a Google PubMed neuroanatomy physiology search on the endolymphatic sac. I mean, that thing, as
Very
tiny
sensitive
as
to
it is,
barometric
is
fluctuations.
so it has a huge effect. Yeah.
Yeah. So all
On
these things,
him, we've said this last video, we talked about the velocity storage mechanism.
yeah.
Just to clarify for people, if I spin in a chair at a constant speed, the initial movement, my hair is going to deflect. And then as I go at a constant speed, the hair is eventually going to meet up to the speed of the fluid, and you're going to be like this. And now you don't have that neurological information going through. So how do you know you're spinning? And it's this velocity storage mechanism in the brainstem that is saying, hey, we're still moving. And
It's heavily
sometimes it can
connected
have a party
to
of its own, and
it
you
can
feel
run it
dizzy.
can run unchecked or it can not charge like it's supposed to, and it's very heavily connected again to this optokinetic system that we talked
Hmm.
about a little bit, which
Yep.
is why they're using it, because that's one of the thought processes with this Debarquement syndrome is it's a miscalibration of this velocity storage mechanism. So that's the thought process is we do this stimulus plus this stimulus and it basically recalibrates that system so that it
Hmm.
can appropriately help you perseverate where you are in gravity, but not for too long.
Hmm. Yeah.
There's a time constant that it should have, and you've got competing systems on the left side and the right side, or more like what we should say is
Dancing.
interacting systems on the left and the right side that should waltz,
Yes.
not an MMA fight. And
Yep.
the problem is sometimes the waltz becomes an MMA fight, and that's where people end up with triple PD or maldebarkment or binocular vision disorder. One of the things you talked about with this Alice in Wonderland syndrome, a lot of
Hmm.
those people get diagnosed at like neurooptometrists with binocular vision disorder. What's that
Hmm.
mean? My eyes don't pair in space like they're supposed to, and
So
you get like,
Let's fuse them from this end
yeah,
and not look at what's directing them, where the puppet show is behind it.
yeah, so they'll get neural lenses or, prisms or
Hmm.
other things that'll help habituate the system to that miscalibration where the eyes don't pair. And it's not so much like a classic convergence insufficiency. You can see
Hmm.
what I'm doing here. I'm not really looking at my thumb, but
Yeah,
what'll
I was like,
happen,
you're not conversion,
yeah,
buddy.
I know. So people with convergence insufficiency, you'll do this, but their eyes won't come in
Hmm.
where, maybe that's pretty good.
That was pretty
You
good.
see
Yeah.
it like it actually
That left
happened
eye
right.
went out a little bit,
Yeah.
but yeah, you were good outside of that.
Well, I mean, hey,
When
it's a
you went away, it was like think with
yeah.
your
Yeah.
whatever
So
eyes.
so or you'll see an accommodation spasm or a convergent
Hmm.
spasm where it
Hmm.
stays in, I'm like,
Yeah.
I'm
Yeah.
making it happen there.
Yeah, you
So
did. You did. That was a
yeah.
good one.
Yeah. The eyes will stick even though
Yeah.
the stimulus moves away. But you have people that have that happen involuntarily. The binocular vision disorder is a little different. It doesn't happen necessarily the same way, but it's happening in their environment over and over where again, what happens when I've got Alice in Wonderland is my brain gets confused because the eyes aren't fused. So is the image from the left eye correct or is the image from the right eye correct?
Yeah. Because in
And
the
the problem
thalamus,
is,
where it first goes, you have those six layers. three from one, three from the other, and they work out that, what they're seeing on its way back to the occipital lobe.
Well, and there's multiple layers of processing in the visual stream. Yeah, the thalamus does processing, the
Mm-hmm.
parietal cortex does processing,
Mm-hmm.
the temporal cortex does processing,
Yep.
the occipital does. And then guess what? It comes back through those areas because it's a dorsal stream and a ventral stream. The dorsal stream telling you, where stuff is, the ventral stream telling you what stuff is. Correct? I think I said that correctly.
I thought it was what, where, but I could be wrong. I always have to
Well,
look that
well,
one up.
parietal. Well, it makes sense to me. Parietal lobe does what? It really is where kind of things are, right?
Hmm.
Where am I in space compared to where is
And I
space?
think it talks to the
Temporal lobe
frontal
is
lobe, which is more
identifying
of a
what stuff
what.
is. Well, and
Yeah.
temporal lobe feeds into that, right?
Hmm.
So temporal lobe gives you context on what things are, comparatively speaking. I mean, I can look it up real quick and make sure I got it right. It doesn't matter. But
Yeah.
anyway, you're filtering back on through before you've made the interpretation for all those things. And it's very, very quick. But the thing that happens again, if I'm not getting information from the same eye, now I've got an extra layer of compromise or problems that are happening.
Hmm.
My brain's doing its best guess to decide which one's right. And now I've got a distortion on where things are compared to where I am in space.
Hmm.
The posterior parietal cortex very much involved in distinguishing where am I compared to where is my
The world.
shaker cup and where is everything between that shaker cup and me so that I don't get confused on where that thing is so that I can travel smoothly and grab it. You
Hmm.
throw in basal ganglionic processing and things like
Which
that
is
so that I can travel
subcortical underneath
smoothly
that parietal lobe. Yep.
that
Base
makes me
go, no
move
go.
smoothly to get to it, but it has to compare where I am compared to where all these environmental objects are. And it's all doing this in real time at like 500 hertz refresh rates, which is very, very fast.
Hmm.
And so that I don't miss the object, spill the object, knock the object off, have a tremor or a freeze or a hesitation so that I get the water to my mouth as opposed to my ear, my shirt, the guy behind me,
Yeah.
all these kind of things. And it's happening over and over and over again, which is why I always hated learning indirect and direct pathways the way that we did in
Brutal.
our classic professional training. Because it's like, well, you
Hmm.
have to turn one on.
Yeah.
Well, yeah, you
They're
have to
both
turn
on.
one on, but the other one's doing the same thing. It's the waltz. I have to use the other one. They're both on at the same
Yeah.
time so that
If
I've
one
got
is more on
equal
than the other,
movement.
that's where the problem is.
Yeah, generally that's what you see. Either I'm not going to move at all or I'm going to move like all over the place. And
Yeah.
the thing that should happen is it should be a nice concerted dance so that it's smooth, perfect movement. So I get activation and co-activation of agonist and antagonist muscles. And I've got a cerebellum that's telling all these things to happen. And all these people with maldebarkment or, any of these other vestibular disorders, what they're fundamentally telling you is I don't know where I am in the world, so none of this other stuff is going to work the way that it should.
Yeah. So when it comes to prisms, neural lenses, I'm like, don't do those first. Let's get some of these baseline things, and if we can't fix them, then use that more as a crutch.
Sometimes there may be a paralysis of an eye muscle due to a childhood trauma, like somebody going
Right.
through a windshield,
Right.
or they may
An
have
infection, a childhood infection
yeah,
that
yeah.
now has created a medial deviation. Yeah.
Maybe they've had enough significant head traumas that they've got permanent change in their dorsolateral prefrontal system and some of these other things, and you're
Right.
gonna have to have some of that stuff because you can only rehab them so far.
Right. Yeah.
Yeah, okay, guess
It's
what?
just
We
the
got to
priority of how you hit it is the
yeah,
is the trick to a lot of it.
we've got a 12-degree skew. We've rehabbed you to a 4-degree skew.
Hmm.
Great, but you still feel crappy. Well, now maybe we need a base down prism or something like that to get that
Yeah.
superior oblique to actually do its full job. Fine. I mean, I've got a neuro-optometrist in town that I work with. Paul Brewer is one that
Yeah.
works with us in the Carrick
Yeah.
program. I love Paul,
Yeah. He
and
does a
Paul
great job.
does a lot of vestibular activations in his clinic. He's one of the few, the vision therapists are starting to go, the
Yeah.
neuro-optometrists and vision therapists starting to go, we need to do vestibular stuff too.
Well, that's one of the things I tell people. I'm like, as a chiropractor, we get access to everything.
It's really cool. Yeah, it's really cool.
Yeah.
So
We're not stuck in it. Yeah.
which is really good. The problem sometimes we become a jack of all trades and a master of none in that
Mm.
as well. Um, so it's good to have people in your clinical network who maybe I don't want to give people prisms, but the neuro-optometrist in
Right.
town will.
Yes.
and he'll do vision therapy, which is a different beast than what I'm doing with people too.
Hmm.
It's like, hey, we can do both for
Yeah.
sure. In some
Yeah.
cases, it's fine. I would rather work with people flexibly than go, no, I'm the only person, and it's like I'd rather help people to whatever
Yes.
degree I can.
Yeah.
Absolutely.
Yeah. All right.
So I know
So
that in a nutshell is the Debarquement case recently. I've had a lot of those, and
nutshell.
again,
That was a
they've
big
been,
shell we went in. We went into
yeah,
a big shell.
a lot of them have been all over the place, and that's the
Yeah.
thing, that graded therapeutic approach that's specific to the person. Again, find a character trained person in your area.
Hmm.
There are so many people that we have through the world that have had training that can help you with this.
Yeah. And they all, I mean, to be fair, we all have a little different equipment, a little bit, we set up our schedules different. I know people who do 15-minute visits. I spend more time with my neuro patients. It varies on the person. And
You may go to a clinic that does neurointensives where they're going to treat you 3 times a day for 5 days and send you, you may go to Dr. Schmo's clinic in Minnesota
yep.
and spend time and then go back to your area. But again, they're going to find you, or you're going to want to find a character trained person in your area, even if you do that. I have people that I've seen that go on to do intensives and then come back.
Hmm. Yep.
It
Okay.
happens. Sometimes they need that. They need more than what I have time for in my clinic.
Right.
Or
Yeah.
maybe they need a gyro stim or something that I don't have in my clinic.
Yes. I can't fling everyone around.
I,
There's
I I
sometimes
can
I
put
can't
you I can
mimic
put you
it.
on my back and airplane spin you WWE style if you want, but
I
a
mean,
little
if there is a
simpler anytime.
WWE fight going on, maybe that's a therapy that's appropriate.
That might be the way to go, but
Yeah.
sometimes you need a little more specificity than what I can offer.
Yeah.
Absolutely.
Yeah. All right. Well, I think this is a good ending,
Perfect.
and we'll talk more about sacudometry, pupillometry,
Pupillometry, vestibular
TAPS.
dynamic posturography. Yeah,
Yes.
absolutely. Perfect.
All right. See you later.
All right, see you next time.